Hello everyone, welcome to the next Saviours Essential Question Series for NEET PG 2025. Today we are going to have a discussion on the clinical questions which are asked in relation to the aortic arch, neural crest and the pharyngeal arch development. You see, 3 to 4 years back, the questions were asked based on the development of the aortic arches, like what is the name of the artery which is derived from the first aortic arch, what is the name of the artery which is derived from the left sixth aortic arch, and so on. But today we are having a clinical question based on these kind of the observations. And if I give you one sample question, that a newborn is diagnosed with abnormal right subclavian artery, a congenital vascular abnormality where subclavian artery arises from the descending aorta instead of brachiocephalic trunk. Now, this is due to the regression of which of the following embryonic structure? So today these questions are getting changed into a clinical perspective. All of us are aware of the fact that aortic arches are the series of the paired embryonic arteries that arise from the aortic sac and connect to the dorsal aorta during early fetal development. Now, these arches undergo remodeling, forming the major arteries of the head, neck, and the great vessels. And how? As we have just talked about, that the first aortic arch results in the formation of the maxillary artery. The second aortic arch results in the formation of the stapedial and the hyoid artery. The third aortic arch leading to the formation of the common carotid and internal carotid artery. The fourth aortic arch of the left side into the aortic arch, but the fourth aortic arch on the right side resulting in the formation of the proximal right subclavian artery. The sixth aortic arch on the left side leading to left pulmonary artery and the ductus arteriosus, while the sixth aortic arch on the right side leading to the formation of the right pulmonary artery. So this is a fate of the aortic arches normally what happens. But what if there is an abnormality? That means what are the possible abnormal regressions of the aortic arches? So first one is the presence of the right aortic arch. This right aortic arch presence is because of the persistent of the right dorsal aorta. And what are going to be the key clinical features which would be provided to you in the question is the aortic arch on the right side instead of the left. Another one is double aortic arch, which is because of the failure of the right dorsal aorta regression. And this is identified as tracheal and esophageal compression in the form of stridor or dysphagia. Another one is the aberrant right subclavian artery, which is because of the regression of the right fourth aortic arch and right dorsal aortic persistence. It will be identified clinically as the complaints of dysphagia lusoria, that means difficulty in swallowing because of the retroesophageal course of the artery. And finally, the patent ductus arteriosus, which is because of the failure of the ductus arteriosus closure, and it will be identified on the basis of the continuous machinery murmur and the presence of left to right shunt and so on. So these are the clinical conditions which are very, very frequently kept in your examination for the purpose of identification. Now, if I give you a sample question like a 60-year-old male presents with dysphagia and chest discomfort, CT angio reveals aberrant right subclavian artery originating from the descending aorta and passing posterior to the esophagus, which embryological structure failed to develop normally. Now, all of you know the right fourth aortic arch normally forms the right proximal subclavian artery, and its regression will result in the formation of the aberrant right subclavian artery, which courses behind the esophagus, causing dysphagia lusoria. So, answer for this question is fourth aortic arch on the right side. So, this is the embryological structure which has failed to develop normally. Let us talk about another question. Like 2-year-old child presents with a stridor and dysphagia since infancy. The chest X-ray shows narrowing of the trachea, and CT scan confirms a double aortic arch compressing the trachea and esophagus. Which embryological structure failed to regress? Normally we know that the right dorsal aorta, it normally regresses, but the failure lead to the formation of double aortic arch, forming a vascular ring that compresses the trachea and esophagus, leading to stridor and dysphagia. So, what is the correct answer? It is the right dorsal aorta, which has failed to regress, leading to the formation of the double aortic arch. So, this is how the questions are getting asked today. Means not only about the normal aortic arch you have to remember, but the abnormalities associated with this, and these are the classical examples which are commonly kept in your questions. Coming on to the next structure, that is neural crest. Now, if I give you a sample question that a newborn who is presenting with the cyanosis, left deviation of the aorta, right ventricular hypertrophy. Echocardiography reveals a large ventricular septal defect with an overriding of the aorta. Genetic testing confirms the deletion of the chromosome 22q11. Which of the following embryological defect is responsible for this condition? So you see, not only the normal neural crest formation you have to remember. All of us are aware of the fact that neural crest cells are multipotent migratory cells which are derived from the ectoderm. They form a border in between the neural plate and the surface ectoderm during neurulation in between 3 to 4 weeks. Now, once the neural tube gets closed, neural crest cells they migrate throughout the body and differentiate into diverse structures. Now, anatomically, neural crest migrates along the four major pathways. The first one is the cranial neural crest, leading to the formation of the skull bones, the cranial nerve, the sensory ganglia, the melanocytes, pharyngeal arch structures. The second one is the cardiac neural crest, which is responsible for the formation of the aorticopulmonary septum, outflow tract of the heart, parafollicular cells of the thyroid. The third one is the truncal neural crest, leading to the formation of the dorsal root ganglia, sympathetic chain, adrenal medulla, melanocytes. And the fourth one is the vagal and the sacral neural crest, leading to the formation of the enteric nervous system. So this is the basic anatomy. But the questions are not asked on the anatomical identification. Rather, they are asked on the defective neural crest migration leading to severe congenital abnormalities. And what are those defects which are commonly kept in your question? One is D-George syndrome, which obviously you are aware that it is because of the failure of the cardiac neural crest migration leading to the features of Fallott's tetralogy, absent thymus, and the parathyroid. Then Fallott's tetralogy in isolation, which is because of the abnormal migration of the cardiac neural crest identified as cyanosis, boot-shaped heart, pulmonary stenosis. Then Hirschsprung disease, which is because of the failure of the vagal neural crest migration to the colon, identified as absent ganglia, leading to the formation of megacolon, delayed meconium passage. Waardenburg syndrome, which is because of the failure of the melanocyte migration, leading to heterochromia, deafness, white forelock, and so on. So these are the clinical conditions which are very, very commonly kept in your question for the purpose of its identification. So if we see this question, like a 2-day-old neonate fails to pass meconium within 48 hours of birth. He developed bilious vomiting and abdominal distension. The contrast edema shows a dilated colon with a narrow segment at the retrosigmoid junction. So, which of the following is the most likely embryological defect the patient is suffering from? Now, the vagal neural crest, they migrate to form the Orbach and the Mischner's plexus, as we have already talked about this one. So, absence of the ganglia leading to no paralysis, leading to functional obstruction, that is Hirschsprung disease, is a feature of failure of vagal neural crest migration. So, this is how the questions are getting identified. Actually, this question is based on the Hirschsprung disease. Next one is a newborn who is presenting with cyanosis, left deviation of the aorta, right ventricular hypertrophy. Echocardiography reveals a large ventricular septal defect with overriding of the aorta, as we have discussed in the beginning of this topic. Genetic testing confirms the deletion of the chromosome 22q11. So we are talking about a question related to the tetralogy of Fallot. And that the neural crest cells, they contribute to the development of truncus arteriosus and bulbus cordus, which forms the aorticopulmonary septum. That means which is responsible for the separation of the aorta and the pulmonary artery. Now, if there is a defective neural crest migration in this case, it will result in tetralogy of Fallot, a persistent truncus arteriosus, or even transposition of the great arteries. D. George syndrome is the syndrome that we have talked about, that it is associated with Fallott's tetralogy and abnormal aortic arch derivatives. So the correct answer for this question is the failure of truncoconal neural crest migration, as we have already talked about related to this particular question. So this question is not asked in relation to identification of TOF. What is the embryological defect behind this TOF? Hopefully you have understood that how the questions are getting framed today. Next is the pharyngeal or the branchial arch. Now you know that the pharyngeal or the branchial arches, they appear in the 4th week of embryonic development, and it contributes to the structure in the head, neck, and the great vessels. As you know that each pharyngeal arch is composed of a cartilaginous component which forms bones and the connective tissue. then the cranial nerve, which innervates the muscle which are derived from this arch, and the aortic artery, which forms a part of the greater artery, as we have already talked about in the aortic arch. So this is the table which you are very well aware of, like pharyngeal arch derivatives or the branchial arch derivatives, which they have asked multiple of the times. But today, the questions are not getting asked out of this table. This is the normal anatomical table. The question is getting asked based on the abnormalities of the development of the branchial arch. Now, coming on to the question based on this pharyngeal arch development, like 2-year-old child is diagnosed with Tracker Collins syndrome, characterized by mandibular hypoplasia, malar hypoplasia, and conductive hearing loss. This condition is results from the defective development of which of the following pharyngeal or the branchial arches? It is the first branchial arch, which is also known by the name of mandibular arch, which lead to the development of the maxilla, mandible, or zygomatic bone. It leads to the development of the Meckel's cartilage, and it leads to the development of the muscles of the mastication, like masseter, temporalis, or pterygoids, along with the nerve, which is mandibular branch of the trigeminal nerve. Now, tracheal Collins syndrome, which is also known by the name of first arch syndrome, it is caused by the failure of the neural crest migration, which is leading to micrognathia, which is small jaw, underdeveloped zygoma, leading to malar hypoplasia, malformed ear structures leading to conductive hearing loss. So obviously the answer for this question is the first branchial arch. It is because of the abnormality of the first branchial arch. Now, why other options are incorrect? You see, had the examiner asking about the second branchial arch, now this second branchial arch forms the Reacher's cartilage, which lead to the formation of the stapes, styloid process, and the muscles of the facial expression. So, if there is a defect in the second branchial arch, then it leads to Peary-Robinson sequence, not the Tracheal-Collins syndrome. Similarly, the third branchial arch forms the stylopharyngeus muscle and the cranial nerve 9, which is not involved in the jaw formation. If you look at the another option, that is fourth branchial arch, then it forms the pharyngeal muscle except stylopharyngeus and the laryngeal cartilages. So it is also not related to the mandibular abnormalities. So hopefully you have understood that how to deal with these sort of the questions. Giving you another question, like a 4-year-old child presents with difficulty swallowing and loss of taste sensation on the posterior one third of the tongue. A developmental abnormality affecting which branchial arch is most likely responsible for this? So you know the third branchial arch gives rise to stylopharyngeus muscle, as we have already talked about, and it is the only muscle which is supplied by the cranial nerve 9. It leads to the formation of the greater horn of the hyoid bone, and the cranial nerve 9, that means glossopharyngeal nerve, it innervates the posterior one third of the tongue, which is responsible for taste and sensation. So, a defect in the third arch will result in the difficulty of the swallowing, which is because of the stylopharyngeus dysfunction, and loss of taste in the posterior one third of the tongue, which is because of the glossopharyngeal nerve involvement. So, answer for this question is the abnormalities in the third branchial arch. As we have just talked about, that in case of first branchial arch, there has to be anterior two-third of the tongue involvement, which is supplied by cranial nerve 7th and the third division of the trigeminal nerve, not the posterior tongue. For the second branchial arch, it leads to the formation of the muscles of the facial expression, which is supplied by cranial nerve 7. So no swallowing is affected in this case. And the fourth branchial arch, as we have already talked about, that it forms pharyngeal constrictors, the soft palate, and the larynx, and the vagus nerve is affected, not the posterior part of the tongue. So this is how another sample question is answered based on what we have learned from the anatomical perspective of the pharyngeal arch derivatives. And coming on to the final question, a newborn is presenting with stridor, weak cry, and difficulty in breathing. Now, laryngoscopic examination reveals poor movement of the vocal cord and hypoplastic laryngeal cartilages. Which of the following embryological structure is most likely affected? Now, all of us know that fourth and the sixth branchial arches, they give rise to laryngeal cartilages and the muscles, right? Fourth and sixth, they lead to the formation of the laryngeal cartilages and the muscles. Now, fourth arch is responsible for superior laryngeal nerve involvement, which is responsible for supplying the cricothyroid muscle, while the sixth arch is responsible for recurrent laryngeal nerve involvement, which is responsible for supplying the intrinsic laryngeal muscles except cricothyroid, and it leads to the formation of the cartilages like thyroid, cricoid, arytenoid, corniculate, and cuneiform. So, if there is a defect in the fourth or sixth arches, it leads to a weak cry, which is because of the vocal cord paralysis. It will result in the stridor, which is airway obstruction due to laryngeal muscle dysfunction, and the breathing difficulties. The answer for this question obviously is the fourth and the sixth branchial arch abnormalities. Hopefully, the session was of some help. All the best for your future examination. In case you do not want to miss any update, join our Telegram group. Link is provided to you in the description.